Good afternoon, everybody. I'm Joan Winsenson. I'm the Executive Director with Conquer Myasthenia Gravis. Welcome to this afternoon's webinar, which is Tell Me About Autoimmunity. We'd like to thank our presenting sponsor, argenx. The other sponsors for today's webinar include Janssen and Celio Health, and we're very grateful for their support. I'd like you to keep in mind that today's webinar, every person's experience is unique when it comes to your medical condition, and this webinar is not a substitute for medical advice. Our presenter today is Ryan Jacobson, Dr. Ryan Jacobson. He's a neurologist and assistant professor at Rush University Medical Center. He has spoken to our group before, and we're delighted to have him back. Good afternoon, Dr. Jacobson.
Good afternoon. Thank you for having me.
I'm very pleased to have you here today. Today, Dr. Jacobson is going to help us understand the concept of autoimmunity and how it relates to myasthenia gravis. His presentation will be about 30 minutes. There will be time for questions after his presentation. So
welcome. Thank you for joining us. The topic that we chose today was Tell Me About Autoimmunity, or Autoimmunity and Myasthenia Gravis. Before we delve into our topic today, I know that Joan had sent out a little bit of a poll gauging your knowledge about this topic, and we actually had 120 folks respond to the question, how much do you know about autoimmunity and myasthenia? 27% of you said I know little to none about how it works. 56% of you said I understand the basics. And 18% of you said I understand a lot. So it's a good spread. And I feel for everybody who said I understand the basics, because the immune system is one of the most complex parts of the body. And as somebody myself who's primarily a clinician, somebody who sees patients and manages treatments, we really scratch the surface on what the immune system is capable of. But living with myasthenia gravis or treating myasthenia gravis, this is an autoimmune disease, and we're going to talk about exactly what that means. We're going to discuss the meaning of autoimmune disease, how it relates to MG. We're going to spend a brief section talking about the thymus. That's a topic that many of you probably know about or have experienced in different ways. And then we're going to discuss the mechanism of different medications for myasthenia gravis and their impact on the immune system. Several of you submitted questions prior to this session, and I'm going to address a lot of those as we go. One of the questions was, are we getting closer to a cure for myasthenia gravis? And I think what is definitely fair to say is our treatments are getting more and more specific in how they act on the immune system. So we're not so much knocking down the entire immune system anymore as opposed to parts of the immune system. And that can have less side effects and more direct impact on the disease. The normal immune system itself is complicated. There are two major categories of the immune system, called the innate immune system and the adaptive immune system. The innate immune system is made up of cells that are sort of like our first line of defense, cells that know how to recognize bacteria and funguses and to attack them, to try to remove them. This part of the immune system, one of its functions is something called complement. You see it on sort of the bottom left there. Complement is a series of proteins that the immune system uses to identify and eliminate targets. You'll see that this will become important on our medication section. The other large portion of the immune system is called the adaptive immune system. This is the part of the immune system made up of B and T cells. And this is the part of the immune system that can produce antibodies. And this is the part of the immune system that has a memory and can remember specific threats that your body did not know about when you were born. Most of the time, that memory is a good thing because you can come down with an infection of a bacteria or a virus and then not be as at high risk for it again. Sometimes, like in an autoimmune disease, that memory is actually a bad thing and can make an immune problem more difficult to treat and longer lasting. One of the questions that we had submitted before the session was, what role does protein play in the immune system? And many of the effectors of the immune system, like antibodies themselves or complement, are made up of proteins. So your immune system uses proteins to communicate and to attack invaders. What about autoimmunity? Well, as you know, autoimmunity is the process where the immune system is directing its attention not towards an invader or a bacteria or a virus, but against some part of the body itself. The reasons why this occurs in an individual are not always clear. One of the most common reasons or hypotheses is what is referred to as molecular mimicry. Molecular mimicry is the concept that the immune system begins making antibodies against an invader or a microbe, and those antibodies just happen to also bind to a part of your body, a part of your nerve or muscle or thyroid gland. And that's what begins the autoimmune process. And this is what's known as molecular mimicry. But in the average person with an autoimmune disease, we don't know exactly why they have it most of the time. There are genetic predispositions towards having autoimmune diseases that we're going to discuss in a couple moments. So in myasthenia gravis, it's really the location of the autoimmune problem that makes MG MG. In other words, antibodies are being produced that happen to bind to the muscle, to the acetylcholine receptor on the muscle, most commonly, or to another protein nearby. And the antibodies are capable of interfering with the chemical input to the muscles, resulting in weakness. So autoimmune diseases come with various antibodies. In myasthenia gravis, those antibodies are specific for the muscles and these specific targets on the muscles, which is why it results in muscle weakness. As I mentioned a moment ago, antibodies are types of proteins, and there are really several different types of antibodies that the body is capable of producing. These are called IgA, IgD, IgE, IgG, and IgM. Each of these has a slightly different function and is not terribly important to us today. IgA, for example, is very common in the body's mucous membranes. IgM is the first antibody that's produced against a new invader or threat. IgG antibodies are what gives us lasting immunity. And these are the types of antibodies that are present in people with myasthenia gravis. They are called IgG subtype of antibodies. And this is going to be important when we get down to talking about some of our treatments. As you know, myasthenia gravis is not the only autoimmune disorder. It's worth thinking about some of these autoimmune disorders for other autoimmune disorders for a couple of reasons. Number one, people with MG can be at higher risk of these other conditions. And number two, a lot of the treatments between MG and other autoimmune diseases are going to overlap. So if you have friends who've been diagnosed with something else or family members who have been diagnosed with something else, they may be on similar medicines to you. So in, medicine, other autoimmune diseases include lupus and rheumatoid arthritis. Thyroiditis or Hashimoto's thyroiditis or hypothyroidism is one of the most common autoimmune diseases. And psoriasis is another example of an autoimmune disease that primarily affects the skin. As I mentioned just a second ago, it is not unusual for somebody with myasthenia to actually have a second autoimmune disorder. And about 15% of patients with MG may have a second autoimmune disease. In my experience, that number may be even higher than that. The most common disease that someone would be affected by would be thyroiditis or hypothyroidism. And the next most common after that would be lupus and rheumatoid arthritis. One of our questions that was submitted before the session was, what about the relationship between myasthenia gravis and diabetes? And people with myasthenia are at slightly increased risk of autoimmune diabetes or type 1 diabetes. That is true. However, the most common reason to have both diabetes and myasthenia gravis is due to exposure to steroids. You're more likely to have a second autoimmune disease with your MG if you were of young or early onset with your MG, probably predicting some genetic predisposition towards developing this. If somebody undergoes a surgical thymectomy, which we'll talk about in a few minutes, that does not protect them from these other autoimmune problems. So this slide I'm not going to spend much time on, but hypothyroidism is very common in the general population. It wouldn't surprise me if some of you had a spouse or a partner or an aunt or uncle who had thyroid issues, and it's super common. And we basically had to do a lot of statistics to prove that yes, people with MG are truly at higher risk of thyroid disease, and it's not just common in them like everybody else, but that risk is higher in the MG population. I already mentioned some other autoimmune diseases, but there are many other autoimmune diseases that we see in neurology or in neuromuscular medicine. I think it's important to have heard of these because if you're seeing a neurologist, a neuromuscular specialist, we often rely on our knowledge from one disease to learn how to better treat another one. So the treatments of these things can overlap in some ways. So MS is an autoimmune disease that affects the central nervous system, the brain and the spinal cord. It's rare for that to overlap with MG, and MS tends to have its own set of treatments. NMO is a MS-like illness, and it's interesting because one of the newer treatments for MG, which is eculizumab or Soliris, is also approved for NMO. Within our peripheral neurology or neuromuscular practice, we also see people with autoimmune muscle and nerve diseases like myositis and CIDP, and even other autoimmune neuromuscular junction diseases like Lambert-Eaton syndrome, where the problem is actually on the nerve ending of the neuromuscular junction rather than the muscle side. I'm going to spend just a few minutes discussing the thymus gland. The thymus gland is a really strange piece of the body or part of our anatomy that lives directly under the sternum or breastbone in front of the heart. And the thymus gland plays a role in training the immune system. And it plays a role in selecting which of your T cells, an important immune cell, are going to be allowed to roam free in your body and which are going to be eliminated. So if your thymus is not functioning perfectly, the immune system can go awry. When we're young, our thymus is sort of a larger piece of active tissue. as we age, typically our thymus shrinks and becomes replaced by fat. And that's a normal process, whether you have MG or not. But the thymus plays a special or unique role in myasthenia gravis. And actually, in a majority of people with autoimmune MG, their thymus is not functioning normally. In many people, they can have what's referred to as thymic hyperplasia, which is when the thymus is overall slightly overgrown. Some people have what's referred to as a thymoma, which is like a benign tumor of the thymus gland that is affecting the function of the thymus. Very rarely, somebody can have a severe thymus cancer, but that is more seldom encountered. So if somebody has autoimmune myasthenia gravis, thymoma can be detected in about 15% of them at presentation. So not many, but not a tiny number either. So we always look for it, particularly in people who have generalized disease and acetylcholine receptor antibody positive disease. If somebody has a thymoma, then myasthenia gravis is present in about half of them. So it's not a two perfect overlapping circles. It's like overlapping Venn diagrams. But if you have a thymoma, you're at high risk of myasthenia. And if you have myasthenia, you're at some risk of thymoma. If somebody has a thymoma, it's like a type of tumor and it should be removed. Rarely, again, somebody has thymus cancer and they need an oncologist to become involved. But what if somebody does not have a thymoma? Well, for a very long time, we didn't know what to do in that situation. But about 5 or 6 years ago now, a randomized clinical trial of thymectomy was finally done, where we saw how people did if they had their thymus out or if they didn't have their thymus out. And to get into this trial, you had to have acetylcholine receptor antibody positive myasthenia gravis. And the doctors who examined them and analyzed the numbers didn't know whether or not their patient had had a thymectomy. The patients had to wear a special shirt to the doctor's visits. Obviously, the patients knew whether or not they had had a thymectomy. And it was shown that there was a benefit to having your thymus out, even if you did not have a thymoma. And that benefit becomes clear after a few months, and then it's present over, at least a few years. People have fewer symptoms, and if they're on prednisone, we're more likely to be able to taper off the prednisone successfully. So the thymectomy has a steroid sparing effect. It's not a cure for acetylcholine receptor antibody positive myasthenia gravis, but the literature would tell us that on average, if you remove your thymus, you're going to do better over the long run. All right, so now we're going to move into our third section, where we discuss medications and autoimmunity. Some of the words that we hear about commonly are immunomodulatory drugs or immunosuppressants. An immunosuppressant is a medicine that reduces the activity of the immune system. It tries to tone down the immune system. So if somebody's immune system is too active and they have an autoimmune disease, an immunosuppressant can help with that. An immunomodulatory drug is a medication that changes the activity or behavior of the immune system. So it doesn't dial it down, but it changes how the immune system acts. And we use this in myasthenia gravis as well. Either of these can be helpful in autoimmune diseases. Now we're going to talk about some specific medications and how they work on the immune system. So one of our questions was, how does pyridostigmine work? And pyridostigmine is mestinon. And pyridostigmine does not act on the immune system. Pyridostigmine is neither immunomodulatory nor immunosuppressing. It acts by inhibiting an enzyme of the body called the acetylcholinesterase. And that increases the amount of acetylcholine that is floating around the body. So while it doesn't turn off the autoimmune response, it attempts to have your body sort of outcompete or compensate for the autoimmune problem by increasing the amount of acetylcholine that is available to bind to your muscles. So mestinon has side effects in a lot of cases. Pyridostigmine has side effects in a lot of cases, but immunosuppression is not one of them because it doesn't act on the immune system. Other treatments that you may have been on or be on or heard about do act on the immune system. So if somebody has symptoms that don't respond to pyridostigmine alone or severe symptoms, then we start looking at medicines that do address the underlying autoimmune problem. The first of these and the oldest of these is steroids or corticosteroids. And most commonly, this is prednisone. And prednisone decreases the autoimmune response by acting on the white blood cells, the B cells, the T cells, and others. And the steroids are somewhat toxic to the white blood cells. And being on steroids keeps your white blood cells sequestered in different tissues and organs rather than floating around in the blood to cause trouble. So steroids are a type of immunosuppressant. Especially at higher doses, they reduce the activity of the immune system. And in higher doses, they have side effects as well. The effect on the immune system is also additive when you combine them with other medicines that act on the immune system. What about IVIG? So IVIG is intravenous immune globulin. And this is basically an infusion of antibodies. Those antibodies at one point in time came from blood donors. Well, we just talked about the fact that myasthenia gravis is caused by your body producing antibodies. Well, why do we want to give people antibodies if their problem is an antibody? The truth is the mechanism is not entirely understood, but it essentially works by distracting your immune system. You receive a random collection of antibodies, and those antibodies bind to receptors on your white blood cells and prevent them from carrying out the destruction that the myasthenia gravis antibodies are asking for. So they interfere with the ongoing autoimmune response by flooding the immune system with other types of antibodies. So IVIG does not decrease the normal healthy function of the immune system, and it actually enhances the function of the immune system. So if somebody has a immunodeficiency syndrome, sometimes they'll receive IVIG to prevent infections. What about plasma exchange? Well, plasma exchange or plasmapheresis removes the plasma from the body, and the plasma in the blood contains the antibodies that are causing the problem. And it also removes other immune active chemicals as well. But it's essentially skimming off the antibodies that are causing the problem in myasthenia gravis. Next, we're going to talk about two medicines that we think of as steroid-sparing medicines. So steroid-sparing medicines are medicines that act on the immune system, whose long-term goal is often to replace prednisone in somebody who's been on prednisone. So both of these are immunosuppressing to some extent. azathioprine, and the common brand name of this is Imuran, actually interferes with DNA synthesis. It interferes with the body's ability to assemble new DNA. And one of the parts of the body that loves to grow and reproduce is the bone marrow or the white blood cells. So by blocking DNA assembly a little bit, your body will make fewer white blood cells and turn off an autoimmune response a little bit. Mycophenolate or mycophenolate mofetil, or the brand name of Cellcept, is somewhat similar in its action. And mycophenolate inhibits an enzyme called inosine 5-monophosphate dehydrogenase. And that enzyme is used in producing DNA in white blood cells. So it's a similar target to azathioprine, but a different biochemical mechanism that it works by. So both of these medicines that people commonly take are used to slow down the production of white blood cells a little bit. Rituximab is an example of an infusion that we use. Rituximab has been around for several years, and rituximab binds to a particular marker on a type of white blood cell, the B cell. The B cells are antibody producing white blood cells. And by glopping onto or binding the B cells, the rituximab decreases their activity and decreases their quantity somewhat. This is also why rituximab is used for lymphomas, because in lymphomas, B cells are growing out of control and forming tumors or leaking into the blood, and we want to get rid of them. In myasthenia, there's not a cancer of the blood cells, but we don't like what they're doing, and therefore we target their activity. Another medication that is been around, for just a few years is eculizumab or Soliris. And the mechanism of this one is different. Soliris or eculizumab works by binding a protein called complement C5. And you'll recall from the beginning of our discussion that complement is a set of proteins that your body uses to target invaders. Well, if there's an autoimmune response, the body will also use complement to target cells of your own body for destruction or elimination. And in myasthenia gravis, complement is one of the types of inflammation or autoimmune problem that is present. So we can inhibit that with eculizumab. Eculizumab was actually invented for some rare blood disorders in which the complement proteins are made defective in an individual. In MG, we're trying to turn off the sort of inflammatory part of what these complement proteins do. In the next few years, we'll probably see other complement inhibitors be brought to the clinic or to the market that are longer acting than eculizumab, which is an every 2-week infusion. And once that infusion wears off, your body will just make more complement. And that's my experience with this medicine, is that a lot of people do fairly well with it, but if you're not getting the infusion consistently, symptoms will come back. In addition, this is a treatment that is really only useful for acetylcholine receptor antibody positive MG. And that's not just because of what the FDA says or what the clinical trial did, but these proteins called complement are probably more dysfunctional in the acetylcholine receptor antibody positive group than in MuSK or seronegative MG patients. So that's one of the reasons why this drug is unique to acetylcholine receptor antibody positive people. The last medicine that I'm going to speak of today is one that you'll probably be hearing more about over the next few months, which is called fcrn. And this medicine has another mechanism, which is that this molecule binds to something called the fcrn, or neonatal Fc receptor. It's called the neonatal Fc receptor. That's not really a good name for it because this is a protein that's present not only in neonates, but in all of us. And this protein receptor plays a role in maintaining antibodies, IgG antibodies, and determining how much IgG antibody is made and survives. So if you block it, the body will actually make less IgG antibodies, like the antibodies that are implicated in myasthenia gravis. So this molecule has been studied. It's been put through phase 1, 2, and 3 clinical trials, and the results are positive. Interestingly, acetylcholine receptor antibody, MuSK antibody, and seronegative patients were included in this trial. So, I would expect that all 3 of those groups would be folks who could potentially benefit from this and who are likely to have access to this in clinic in the futures. So there are consequences to turning off an autoimmune problem, which are that you're going to lose some desired activities of the immune system as well. And some of the things that your immune system does is it looks for infections, and it also helps look for tumors. And if somebody has an early or mild tumor in the body, in a lymph node or something, your immune system can actually destroy those. But if your immune system is greatly diminished, the long-term risk of malignancy or cancer goes up. This is true with medicines like azathioprine or mycophenolate. And being on those medicines for many, many years can increase the risk of lymphoma. And this is why. It's because your immune system is no longer able to have surveillance over the body as well as it did before. So we always want to be reevaluating whether or not someone needs to be on immunosuppression for their MG right now. There's also infection risk. Often this infection risk is low, and other than washing your hands and these days wearing your mask and getting your vaccines, those risks are manageable. But there are some exceptions to that. So if somebody is on multiple medicines or high doses of medicines, sometimes your doctor will prescribe an antibiotic to prevent rare types of pneumonia that you're at risk for. And that's because not all parts of your immune system are likely functioning normally to look out for those things. Other treatments leave you at particularly high risk for certain infections. And the one that we talk about the most is in people who are receiving eculizumab or Soliris, there's heightened risk of meningitis, which is why your doctor counsels you on receiving those vaccines before you start, and then receiving boosters. Now, before I conclude, one of the common questions that we got was, what about COVID vaccines and MG? There's really 2 topics there. One is, can receiving a mRNA vaccine make your MG worse? The short answer is probably not, but it is rarely described. When you receive an mRNA vaccine, it induces your immune system to see a new type of protein and develop antibodies against it. Those antibodies should not be against your muscles or neuromuscular junction, but sometimes it just wakes your immune system up a little bit, and people can have more symptoms. Another question that we get a lot is, if I'm on medications for MG, will I mount a normal response to the vaccines? The short answer is much of the time, yes, but your the robustness of that response may be less. Right now, I don't routinely check antibodies in people who've received vaccines. What I really harp on is getting your vaccines, getting a booster, and talking to your friends and family about also getting vaccinated, because that's how we're going to protect as much of us as possible. And we're more vulnerable to infection if we have MG, and our friends and family can be vulnerable as well. So it's something that we can do together to help one another. All right. So that was all that I had prepared today. We have some time for some questions, I think. I'm going to stop sharing my screen.
And I'm going to join you if that's all right.
Absolutely.
Okay. Did you have any other questions from the ones that you got in advance? That you wanted to address, at least, or that you could hear?
I'm going to take a look at one more time for the ones that I flagged.
Okay.
You know, one of the most common questions, you know, this time and last time is, what about the different types of MG? Acetylcholine receptor antibody positive, MuSK positive, and seronegative, although there are other antibodies that we're now occasionally testing for, like LRP4. Acetylcholine receptor antibody positive is the most common antibody subtype. If you have a MuSK antibody, your antibody is probably attacking a slightly different part of the muscle nearby that's responsible for helping to maintain healthy acetylcholine receptor antibodies. For the MuSK people, the autoimmune attack is a little bit different, and people will respond to different treatments a little bit better. So oftentimes IVIG doesn't help them so much, and plasma exchange is better, and rituximab works really well if you're MuSK positive. What if you're seronegative? Well, you know, the general thinking in seronegative MG is that something quite similar is happening, but we're not smart enough to figure out what that antibody is and exactly what it is attacking on the muscle. And we don't have a blood test that can turn it that turns positive to show what that is. So if you have seronegative autoimmune MG, we would still use treatments that reduce an autoimmune response with the idea that your MG is autoimmune and can respond the same way.
If you're ready, I'll start in on the questions that I've received. Okay, let's see, going down. Can you comment on this? I hope they won't overlap with what you said, but can you comment on MG and double vision? Could this also be caused by a companion autoimmune disease?
Good question. So there's two different things that I would say about that. One is that sometimes thyroid problems cause an eye disease, especially hyperthyroidism or Graves' disease, and that too can result in double vision. So depending on your symptoms and your physical exam, it wouldn't be unreasonable for your doctors to make sure that your thyroid isn't somehow contributing to the eye problems. In terms of treating double vision in people with MG, it turns out that it's really hard because, you know, many of you have experienced double vision, but if you have double vision, it's sometimes quite disabling right off the bat. And things can be closer together, farther apart, but if it's double, it's double. And in order for you to get double vision, your eyes only need to be a little bit misaligned. So in order to turn off the immune system, to make that go away 100% and make your eyes align perfectly, that can be hard. If you have strength in your shoulders and we get your shoulders 90% better, you'll probably be fairly happy. But if we get your eyes 90% better, we might not have really done much for you. When it comes to what works for that, oftentimes prednisone or steroids are the only thing that makes a lot of progress on the double vision, which obviously comes with side effects. So sometimes we do try other things like mycophenolate or IVIG for people who have even purely ocular symptoms, but it can be a challenging dilemma for that reason.
Okay. What therapies are available for people who have chronic, lifelong, low white blood cell counts?
So if you're running low white blood cell counts, the question that will have to be figured out is sort of why. If you've really been like that your whole life, some people just fall off the bell curve of what the laboratories say is normal. Other people have a genetic quirk or predisposition to make fewer white blood cells. So if it was always like that, it might be one of those things. If it's only since being treated for MG with something that's affecting your immune system, it can be a side effect of those treatments, and your doctors will have to monitor for that. Sometimes it's useful to see a hematologist, depending upon what your blood abnormalities are, and they can evaluate whether this is a worrisome pattern or something that deserves further attention, or if it's just the way that you are. The other thing I would add, speaking of white blood cell counts, is that when you're on a lot of these treatments, we monitor your white blood cell counts, especially azathioprine and mycophenolate, those steroid-sparing medicines. Your doctor periodically checks your white blood cell count to make sure that it's too low. If it's too low, that could predict a higher risk for infection. So we can look at, if just when you get a blood count drawn, we can look at your white blood cell count, we can look at your lymphocyte count and see that the drug is working, but not too well. Opposite side of that is if somebody is on steroids, many of you have probably noticed this, your white blood cell counts tend to run high. And that's because one of the steroid effects is it pushes some of your white blood cells out of your bone marrow and into the blood. So when you take out a sample of blood, oftentimes the level is running higher. That's especially true when you first start steroids.
Okay. What are the long-term risks of CellCept use, and how high are the risks? You mentioned infection. Is there anything else you'd like to add?
So, infection is one thing. The other thing that we think about is the risk of developing different types of cancer or malignancy in the very long run. I can't put a good number on that for you. And I tend to think of that risk as, this is my own bias or practice a little bit higher in azathioprine than in mycophenolate. And my general advice would be, we worry about this more in really young people. So if you've got severe MG and you're 21 and you're going to be on different medicines for 60 years, that's a lot of immunosuppression to be on over your lifespan. If you're 73 and you just want to get back to doing what you want to do, those risks aren't going to accumulate as much. Second is you always want to, with your doctor, be reassessing how you're doing. You don't want to be just on azathioprine or mycophenolate or prednisone forever, with no reconsidering of how you're doing or if you need it. If somebody has been asymptomatic or in a remission or having minimal manifestations, or however you want to put that, for an extended period of time, it's always reasonable to think about reducing your medicines and seeing how you do over time to minimize some of those risks in the long term.
Okay, here's one. Can MG cause autoimmune hearing loss?
Not commonly. That is not a manifestation that I am aware of or that I have encountered.
Okay. Can you have more than one type of MG?
So that is described very rarely. I have never recognized that myself. Very rarely, if somebody has acetylcholine receptor antibody positive disease and lot of weakness up here and shortness of breath, and which are common symptoms in MuSK patients, we might recheck that antibody. Or if somebody has MuSK and has a lot of ocular symptoms, which is more common in acetylcholine receptor antibody, although you can get that in MuSK too, sometimes we'll check the other one. The reasons that you might think about doing that are, it's interesting, but it's not purely academic. The treatments vary a little bit. So if you're acetylcholine receptor antibody positive, you can get eculizumab, whereas you can't otherwise. And if you're MuSK positive, then rituximab becomes a really good treatment. Whereas if you're acetylcholine receptor antibody positive, people can really vary how they respond to rituximab. So sometimes it's worth revisiting and an interesting discussion to have, but rare.
Okay, we're getting close to our end time, and I want to get a couple more of these in. Can you comment on the overlap? This might be weird, not fair. Overlap of MG and CREST syndrome.
So CREST syndrome is a connective tissue disease, an autoimmune connective tissue disease that's related to scleroderma, which is sort of related to lupus. So in that family of autoimmune connective tissue disorders. And an association is positive and is possible. Not commonly, because they're two rare disorders. So although, to those of us in this group, myasthenia doesn't feel rare. To people who don't know about it, it is. It's having two rare things with you being at heightened risk of having each of them. So there aren't going to be many people like that, but it's possible. In that situation, you want to have a neurologist and a rheumatologist who understand that you have both and can weigh treatments that might have overlap and where their effectiveness would be in treating both.
Okay. There's one. I was taking gabapentin prior to my MG crisis. I was having IVIG, then it migrated under my skin. Next day I was totally weak and could not stand or walk. What effect could gabapentin have on muscles? I've read that MGers cannot take gabapentin. What effect does this have on muscles to weaken them?
So the effect of gabapentin, for those of you who aren't familiar with the medicine, it's like a type of nerve pain medicine that was invented for seizures, but we use it for nerve pain, muscle pain, back pain, cramps. Many people with MG have those symptoms just like everyone else in the population. So it's a commonly used medicine. And it acts on salt channels on nerves for the most part. So it doesn't really get into the neuromuscular junction where the problem is in myasthenia gravis. So we don't think of it as a toxin to be avoided in MG, but it can have side effects that are very alarming in MG. Side effects can include fatigue, dizziness. It can make people feel kind of floppy or out of it. And in the setting of somebody with severe or tenuous myasthenia gravis, those symptoms can make the picture look worse. So not a strong neuromuscular toxin like some antibiotics are, for example. But I wouldn't be shocked to hear that it made somebody feel worse either.
Okay, how about if we do one more and then we'll wrap it up. Although I've got a few more questions, so I may talk to you later about trying to get those answered.
Sure.
Okay. Can you talk a bit more about it, the infection risk if you're taking rituximab? Is it, for example, is it safe to be around people without a mask if they're vaccinated?
So, my general advice is that in terms of COVID precautions, you want to follow your comfort level and guidelines from the CDC and other health authorities. So if we're at a state in the pandemic where they say, vaccinated people can go over to one another's home and not wear your masks, then that applies to you too when it comes to COVID. You, in general, want to practice good masking, be vigilant, and do your hand washing. When it comes to rituximab, if you've received rituximab, you probably already know this, but it predisposes towards worsening a pre-existing infection somebody could harbor, like hepatitis or chronic TB. So sometimes if you see an MG doctor or you're seeing a doctor considering rituximab, they'll check those things on you to make sure that you don't have a chronic infection that could flare up. But in general, you want to be vigilant. You have my license to be as conservative as you want to be, but it's okay to follow the guidelines and just be careful too.
If you appreciated the information here today, please consider a donation to support our ongoing work with myasthenia gravis patients. And one last thing, if you'd like more information about myasthenia gravis, I welcome you to visit our website. It's at www.myastheniagravis.org. Thanks and have a great rest of your day. Bye-bye.